Welcome to The Exam Room, the podcast where we explore how value-based care is transforming healthcare for the better. From probing today's challenges to charting innovative breakthroughs, we're here to dissect what's shaping the future of patient-centered healthcare. I'm your host, Rhiannon Windsor, and we're charting the course through patient engagement. Let's grab in and get started. We're continuing our conversation with Sonia about engaging Medicare beneficiaries. So we're going to talk a little bit about what not to do. We've had a lot of conversations centered around what to do, best practices, those kinds of things. So we're going to spend a little time talking about what not to do. Sonia, have you identified any common mistakes that you see those doing outreach make when they're trying to re-engage with patients?
Absolutely. I think when they approach their outreach as a checklist and they come at the beneficiary like they want to sell them something, for example, care management, or immediately trying to get the beneficiary in for an annual wellness visit, it really turns the beneficiary off approaching this outreach like this. We're supposed to be building relationships, not immediately getting something from the beneficiary. And their view of somebody giving them a call to immediately make an appointment, that's not engagement. And so it immediately turns the beneficiary off. And they don't want to engage. And they don't want to make the appointment. It's addressing what they want and need. And then you can work in what you think is also beneficial for them, which, by the way, is what you're looking to achieve. If it's, for example, the annual wellness visit, you really want them to get that taken care of, you're not going to get that on the first call. But if you can build up their trust, you can explain to them why that annual wellness visit is important. And if they trust you, they're going to act and get that taken care of.
It makes me think of the concept of customer service, which I think we don't do as good of a job as we could do in healthcare with the customer service piece.
We get into that mindset that we've got to get through a certain number of patients in a day. We've got to see a certain number of patients in a day or make a certain number of phone calls in a day. And none of that's based off of patient engagement. Those are numbers, but they're not based on patient engagement.
You go to a restaurant and they treat you like they would in a clinic, and it just probably would never go there again.
Everyone would receive the exact same meal, the exact same seating arrangement. The waiter or waitresses would act the exact same way, and it would be a terrible experience. You wouldn't go back to that restaurant. If you're thinking based off of what the beneficiary wants or the patron who's going to your restaurant, they are able to sit where they want to sit in the comforts that they want. They'll have differences when it comes to their waiters or waitresses, personality differences, their efficiency differences, as well as ordering the food that you want. And you're more likely to go back to that restaurant.
And I think we've talked about it before, but with our Medicare beneficiaries, autonomy is a big thing, taking away their car or the things that they just used to be able to do to have their independence, giving them their autonomy, how they want to be cared for, what kind of care they want is really important.
Letting them have a say is very important to them. And if they tell you, I don't want help with my doctors, I like my doctors just the way they are, that is completely their choice. And if they feel that that portion of their healthcare is being well managed by them, don't question them. Trust that they know what they're talking about. They might need help somewhere else, though. They might not know who to call because their air conditioning just went out and it's the middle of August. They've got 6 different fans going in the house, and they can barely hear the conversation that you're having because of the noise in the background. They might need help there, and they would be happy if you could help them there. Yeah. And that might be where you need to help them.
Have you ever tried to approach that backfired on you?
This is the conversation I didn't want to have, right?
It might be.
I got a little ahead of myself, and I made an outreach call to a beneficiary who had recently been in the emergency room. He was not very happy that I contacted him. Apparently, I had woke him up from a nap. It was very bad timing on my part. And after screaming at me using foul language, he hung up on me. And then I got arrogant. And 30 minutes later, I called back thinking that I could win this guy over. That did not happen. In fact, it backfired even worse. He pointed out that I had the audacity to call back after he had already hung up on me once. And he proceeded to do it again. Now, that's the only patient I personally have lost. However, we did regain him by having somebody else call him back a few days later, after he had forgotten about my phone call, thank goodness. Though they didn't get very far with him, they did get the name and number of his children who they could talk to because they had power of attorney. And so now we are managing his care through his power of attorney. So we did get further than we were, and it knocked me down a couple of notches.
So how do you encourage others that are doing outreach and might have a similar experience?
You learn from your mistakes. Not every call is going to be perfect. Don't take it personally and become arrogant like I did. Keep trying, but keep trying the right way. Don't give them 30 minutes to cool down and call them back. That might not work.
Thanks for sharing that. It was a very good example. What are your thoughts about actions or language that you want to avoid so that your beneficiaries don't feel threatened, judged, they don't become defensive with you? Language or actions you would want to avoid so that the beneficiary doesn't feel judged or defensive?
Language, I would say I leave out a lot of the medical terms. I want layman's terms. I want them to understand what I'm saying. Actions, I would say I immediately want to listen to everything they say, acknowledge that I hear what they're saying, and don't immediately assume I know what they're going to say. Everybody's experience is different. I might have heard it before, but this time I'm going to hear it differently. And that's important. Let them tell you their story, what they're going through, and don't immediately assume. And I never would judge them based on anything that they're explaining to me that they've had difficulty with or that they need help with. Everybody's life is different. Everybody's experiences are different. And when they tell you something, especially something that they need help with, that's very vulnerable for them. Mm-hmm. And I would never want to judge them and make them feel like I'm judging them based off of something that they're telling me. I would rather encourage them that we're here to help and get through it together and not make them feel less of a person because of it.
Right. I was just thinking about finding that balance between keeping the language and the conversation simple enough, but and not so technical, but also not making them feel like they're dumb.
A lot of times, some of the medical conditions they know a lot more about than I ever would, especially if I've never had that medical condition. And so I will even let them educate me on it. If they can educate me on it, I think that's great for future use. Mm-hmm. They don't immediately assume that you know everything.
Right.
You might know how to help them in a certain situation, but you might not know everything about their medical condition, and that's okay. And they're happy to tell you about it and why it's this or that. And Giving them the chance to speak about it, I think makes them feel more empowered about taking over control of their health. And that's important to these people.
Yes, I think empowerment is a big part of it. Not going in with like guns blazing, like you need to do this, you need to do this, you need to do that.
I'm not one to tell them what they need to do. I'm just here to help them do what they want to do so that they can feel better and they can be healthier.
Right. And I know when we're doing outreach, let's be real, we have an agenda.
We do.
There's something that we want them to do, something we need them to do.
Absolutely.
What would you say is like the best way to navigate that so that they're not left feeling like we have an agenda?
Don't expect it to happen in one call. Make them realize that you're here to assist and prove that you're here to assist them and offer your help. Become a resource to them that they rely on. Because if they start viewing you and your organization as a solid research that they can reach out to whenever they need help, they're also going to value your opinion. And so when we are doing outreach, because we have an agenda, we need them to follow up with their primary care physician on a regular basis, or we want them to get their annual wellness visits or breast cancer screening, etc. done. They're going to value your opinion on why that's important. If you don't have that relationship, they're not going to do those things.
Score. That's a great point.
There's all different kinds of negative responses from patients. Just the one that hung up on me was not a win for me. All the others I have won. Reassuring our position and what it is that we're trying to do for them. Making them feel comfortable. Making them understand that we see why they would be hesitant. And we understand the complexity of the healthcare system and how confusing it can be for patients to get through. Letting them know that as a Medicare beneficiary, they're entitled to utilize our service for absolutely for free, just to get them through, just to get them over the hump to living healthier, better, and comfortably for themselves, not for anyone else, not for us, not for the company, but just for themselves. When they start to realize that, wow, we really do assist helping them, they really just start to open up and feel comfortable talking to us, which is where we want them. We want them to feel comfortable talking to us.
What about quick fixes? Are there any quick fixes that either, and we can look at both sides, like the beneficiary side, the outreach side, that people try, but they don't get the consequences that they want, or the results that they want, rather?
Yeah, the quick fixes on the beneficiary side, they think going to the hospital is a quick fix for everything. We see a lot of beneficiaries these days who are having a difficult time getting an appointment with their primary care physician. We hear them say a lot that even if they get an appointment, they're just seeing the physician's assistant and not their actual PCP. And it's frustrating for them. So rather than even attempting to make an appointment any longer, they're just going to the emergency room. The problem with that is they're making themselves susceptible to other ailments. They're getting stuck in waiting rooms with people who have COVID. They're finding that they're becoming ill with something else after they've left the hospital. What they thought was going to be a quick fix turns out to be a long wait time, very little assistance. Maybe their direct need wasn't even addressed. And they're kind of back to square one or worse.
In the ER, they don't look at the whole person.
Nope.
They just look at that one little thing, if they're even looking at that.
Correct. Without evaluating the whole person and getting the whole picture, I don't think that they're getting the proper care that they need. The emergency rooms really should be for emergencies.
Right.
A car accident warrants a visit to the emergency room. A patient who has COPD shouldn't warrant a visit to the emergency room if their COPD is properly managed.
Right.
And people who have chronic ill conditions, as we know, are more susceptible to other things.
Mm-hmm.
We don't want them in those situations. If they're properly managed by a PCP, they shouldn't end up in the hospital for it.
And so do you find that you're having these conversations with our beneficiaries?
Yeah, and after they've made their visit to the emergency room and they've had a negative outcome, they start to realize that maybe that wasn't the best quick fix that they were looking for. And they start to open up to other ideas. It may not be directly back to the PCP, but even getting them into an urgent care versus a hospital is better than the hospital. So quick fix for the beneficiary outreach people is immediately assuming that you know what they need and throwing different program services at the beneficiary without really doing your research, without really listening to the beneficiary tell you what they've gone through, who they've gone through, what they've researched themselves, will discredit you. Immediately saying, oh yeah, I have a fix for that, without hearing them through entirely, I think the beneficiary really starts to look at you as not reliable.
Right.
Too quick to jump the gun. And they feel as though you're not going to be a quality resource for them. And we don't want to do that. We want to make sure that they feel comfortable coming to us and letting them know we're putting the effort in to find them the best fit for them. Not just automatically throwing out program names and numbers and where they can go for this or that. We're taking their situation seriously and putting in the effort to find the best match for them.
Like holding their hand and guiding them through
each assistance they're requesting. Yes.
Thank you for joining us in The Exam Room, where we examine the vital signs of value-based care and diagnose what's shaping the future of healthcare. We hope this conversation on patient engagement was as insightful as your last checkup. A big thank you to our guest speaker, Sonia Sonato, for sharing her expertise and prescribing actionable ideas. Stay tuned for more episodes as we probe the topics that matter most in value-based care. I'm your host, Rhiannon Windsor. Until next time, take care, and thanks for listening to The Exam Room.